International Medical Forum. We are meeting on 1st of June 2024. It's 9:30 a.m. in Delhi. We are experiencing a very heated weather over here. We have just encountered 52 degrees Celsius, and we've been got a request that we'll have a session on hydration and how to handle the heat stroke. So we will arrange that session soon. Today we have Dr. Ratan Jha. Dr. Ratan Jha has worked as a nephrologist and DNB training teacher for over last 3 decades and is considered as the best nephrology doctor in Hyderabad. He's also been invited as a faculty for many national conferences. He has been an NBE Delhi examiner of nephro super specialty for several years. He has authored multiple book chapters, participated in various clinical drugs, trial, and nephrology. Today we are talking about acute pyelonephritis, and to discuss that, we have Dr. Jha with us. Dr. Jha, the platform is yours to give us. Thank you.
Are my slides visible?
Yes, sir, it is visible. You can just make it large.
Yes, visible.
Perfect.
Yes. Good morning to all of you who has come to listen to my talk on acute pyelonephritis, which is a disease which can also get precipitated by heat stress, because if we get dehydrated, we are not passing enough urine, that risk of urinary infection can increase in predisposed. So this may be an appropriate topic in the context of the heat wave, which is prevailing throughout the world, and in India we are facing this problem at this point, which is never been seen before. So I am going to confine my talk on a specific issue of acute pyelonephritis, though it is many times difficult to segregate the acute pyelonephritis from the cystitis to begin with. What I am going to highlight is what are the newer kind of information available in this context. So what, as a nephrologist, I have seen in clinical practice is that there's a bit of inertia in the physician's mind when they see a patient with symptoms which is referred to as lower urinary tract symptoms with or without fever. Because many times lower urinary tract symptoms are just casually treated as urinary tract infection, which may not be the case. Pyuria, that is presence of few WBCs in the urine, is considered as if a sine qua non for the UTI, but that is not the point. It is an overdiagnosis of UTI based on this non-specific urinary finding many a times. We also see that there are not enough kind of effort to inform the patient that how to collect urine for urine culture, and this may have a kind of social taboo, particularly in females, how to explain them, but that can be done with a printed kind of format for how to collect the urine sample, because we may say midstream urine, but the patient may not understand how to collect the midstream urine. So that gives a false kind of urine culture report. We get a falsely contaminated urine sample as a bacteria present, and we start giving treatment on that, and that produces unnecessary drug-related side effects. And many times we have seen that person gets inappropriate drug based on the culture report, because we think that whatever is the culture report, based on that, the antibiotic has to be prescribed in UTI. For example, nitrofurantoin, if prescribed in a patient who has pyelonephritis, is going to be ineffective because the drug doesn't reach the concentration in the kidney parenchyma. And we have seen chronic antibiotic misuse for non-infected dysuria or sometimes asymmetrical kidney being treated as a kind of pyelonephritis or chronic pyelonephritis. And that means that besides drug side effects, there is a kind of drug resistance that happens in the body because the antibiotic exposure changes the bacterial flora. And that produces a kind of ESBL strain, that is extended spectrum beta-lactamase resistant bacteria or multi-drug resistant bacteria in the system, which if becomes systemic will be difficult to treat. So inappropriate use of antibiotics has led to an emergence of bacterial resistance in our country, and this is also one of the factors where we are using it indiscriminately based on the perceived notion that pyuria or some lower urinary tract symptom is equal to UTI. So my presentation is going to cover the following aspects that is shown in this slide, that will give an overview with what is complicated versus uncomplicated, because the terminology has changed. How do we diagnose UTI, whether it is an upper urinary tract infection, which is acute pyelonephritis, or lower urinary tract infection? What are the guidelines and what are the changes in treatment which has been reported in recent time, and antimicrobial options and treatment guidelines in the background of emerging resistance of drug drug resistance to antibiotics. I have just put this slide just to highlight the point that this is a misdiagnosis analogy, that concept of treating pyuria as equivalent to UTI is analogous to an STD changes in ECG suggestive of ischemic heart disease. So one has to understand they are not equivalent. Like when we find STD changes in the ECG, many times people get treatment for ischemic heart disease, but that could be seen even in patient anemia, hypertension. So one has to understand that this is not equivalent. The picture which is shown on the right side of the screen is a patient who has come with acute breathlessness, and what we see in the CT pulmonary angio, that there is a kind of pulmonary thromboembolism that is there, but patient was having in the urine few pustules and was getting treatment with ceftriaxone in addition to the treatment for the heart disease they presumed to be because of ischemic heart disease, but was a patient of pulmonary thromboembolism. Just to highlight the point that many times we overtreat a patient just based on the urinary abnormality, and hence we should be clear that one is not equal to the other unless the clinical picture is compatible. The UTI, therefore, whether upper urinary tract infection, which is referred to as pyelonephritis, or lower urinary tract symptom, is diagnosed in presence of organism which is more than 10 to the power 5, that is 1 lakh organism per ml of urine, with or without symptoms. It has been reported that if we have a lower count, 10 to the power 2 to 10 to the power 3 to 10 to the power 6, it could still be a UTI if the patient has symptoms which is appropriate. But the classical definition of UTI is the presence of 10 to the power 5 coliform units in per ml of urine when cultured. And this has to be supported by urine microscopy, which usually has pyuria, bacteriuria, by the urine strip test, which is an easy test to document the finding that it is urinary tract infection based on the leukocyte esterase test, which is a marker of presence of WBC, and grist nitrate test, where the nitrate gets converted to nitrite by the gram-negative bacteria, like commonly like E. coli and Klebsiella. And this has to be always combined with clinical features. So all the things are important, like this presence of coliform unit in the appropriate range, urine microscopy, urine strip test, and the clinical features. And if all 1, 2, 3, 4 are present, then this is definitely UTI, which has to be treated. So the classification of UTI in the previous time was like uncomplicated UTI or a complicated UTI. But the term is complicated or uncomplicated means that patients who are having a complicated kind of UTI will require a longer type of treatment. They are at higher risk of complication and higher risk of recurrence. But this terminology has been now redefined. It is said that we talk about UTI as only 3 or 4 categories. The cystitis, that is earlier called lower urinary tract symptom. Lower urinary tract is an uncomplicated UTI in most of the situations, except few, like a patient who has a kind of prostatitis. The lower urinary tract kind of infection is considered as a complicated UTI. The cystitis in general is an uncomplicated UTI and it requires shorter treatment. Anything beyond cystitis could be a complicated UTI in presence of risk factors. Acute pyelonephritis is either an uncomplicated UTI or a complicated UTI based on presence of diabetes, obstruction, transplant, pregnancy, etc. So if you have a kind of acute pyelonephritis plus, that is, person has a kidney infection along with some other kind of additional factor, it is called complicated UTI. To decide that this patient needs to be followed up with appropriate investigation and may require a therapy long-term for prevention of recurrence. ABP is a kind of UTI which is called acute bacterial prostatitis. Though it is a lower urinary tract kind of UTI, is considered complicated because there is a risk of recurrence, and many times the diagnosis is not made because it is not suspected. This is one of the common causes of recurrent UTI in males. Term CAUTI, that is a catheter-associated UTI, also has been defined because patients who are living long many times are having a catheter in place which may not require therapy, and asymptomatic bacteria has been classically clearly defined to make the point that you should not treat this disease. So these are the recent division of UTI, and we are going to focus on acute pyelonephritis, which is either complicated if it is associated with the risk of associated risk factors like diabetes, which is the commonest thing, or a kind of obstruction because of stone or because of prostate or a pregnancy. The presentation of UTI in general, whether it is acute pyelonephritis or it is cystitis, could be any of the combinations. Lower urinary tract symptoms are in the form of dysuria, frequency, urgency, that we say as fun symptoms, the frequency, urgency, nocturia, and dysuria. Upper urinary tract symptoms could be back pain, chills, rigor. This is a classical kind of pyelonephritis. And sometimes there is a presence of fever with no clear-cut localization, which is called urosepsis, where the kidney is involved, but that is not giving a clear-cut picture. And it's called occult pyelonephritis, where you have a urosepsis as a presentation. Few patients can have a vague chronic ill health, that is, they are not well and they are having repeated bouts of fever. And this could be because of the presence of pyelonephritis of a subacute nature because of other associated problems. And there's a term called purple urinary bag syndrome, where the urine looks red as if person has hematuria, but that is because of chronic stasis in the urinary catheter, giving a picture like a hematuria with associated asymptomatic bacteria. So this may be the ways the patient can come to a clinician's notice for treatment. So to re-emphasize again, the clinical recognition of upper urinary tract infection, which is less than 1% in the overall UTI picture, is lumbar pains, shaking chills, loin tenderness, and occasional hematuria. Lower urinary tract infection, which is called cystitis, is usually associated with frequency, dysuria, urgency, frank hematuria, suprapubic pain, small void, that passing urine, very frequently small amount, foul smelling urine, cloudy urine. And there could be a situation where this patient may have a kind of bacteria, but there may not be any symptom. So this was a recent kind of a paper that I found quite useful, that when you say a patient has acute uncomplicated cystitis, the key method of diagnosis is looking at the symptoms, which are very simple to look at: frequency, urgency, dysuria, with suprapubic pain, feeling like a prior history of UTI, absence of vaginal symptoms in females, absence of systemic symptoms like shaking chills or rigor, and absence of upper urinary tract symptoms like pain in the back. If this is not there, this is a classical uncomplicated UTI and may require only a urine analysis to support a diagnosis by pyuria and dipstick to say nitrite or leukocyte is positive. Culture may not be required. It can be treated empirically. But it may be required in situation where the person has a recurrent kind of UTI, where one has to look at, is there any kind of drug resistance. So if you look at 100 patients who are having a kind of low urinary tract symptom, 70% of patients will have a classical picture of bacterial cystitis with a colony count in the right range of more than 10 to the power 5. But 20% of patients will have same symptom with a lesser colony count of 10 to the power 2 to 10 to the power 4. And still it will be considered as a true UTI. In patients who have kind of low urinary tract symptoms, 15% of patients may have a kind of urethritis because of chlamydia, herpes, or Neisseria, where we may not get any kind of bacterial growth. So that is a kind of low colony forming unit with the same symptoms. So 70% are having classical bacterial cystitis, 15% have a urethritis because of STD related organisms. Vaginitis could be another cause of the same symptom. 5% of people may have Candida or Trichomonas infection, and it has to be always excluded in females. 1% of patients may have a kind of irritation-related these symptoms, like the estrogen deficiency or using some chemical irritants for cleaning purpose can produce a kind of similar symptoms. And 10% of patients we do not find any cause, and we say a chronic urethral syndrome. That is a kind of psychological kind of problem that is there. So one has to understand that when the Lutz symptoms are there, it may be cystitis because of bacterial infection, or urethritis, or vaginitis, or maybe a kind of psychological problem that has to be appropriately evaluated rather than giving antibiotics in general for all. But one has to also remember that there are many causes of lower urinary tract symptoms which are overlooked or treated a UTI. That is, for example, lifestyle causes like less fluid intake, spicy diet, lower amount of urinary output because of the heat stress, where the urine becomes concentrated, can give a dysuria, and which should not be equated with UTI. Neurological problems and neurogenic bladder or normal pressure hydrocephalus, where the person has a kind of frequency and incontinence, can be misdiagnosed as a kind of UTI, and patient keeps on getting treatment in this regard without any benefit. Bladder outlet obstruction because of prostate cancer, urethral stenosis, particularly in females, bladder calculus, cancers can many times get diagnosed as wrongly as UTI without any benefit. And then many drugs which produces a kind of symptom which is mimics like UTI, like a person who getting diabetes will keep on having more frequent urination, or caffeine, that if people who are taking a lot of coffee or tea will have frequency of urination, and if they're taking less amount of fluid, they can have dysuria. So these are the overlooked cause or overdiagnosed cause of UTI, which may not be the case. But one has to understand that all the symptoms pertaining to kidney may not have a kind of clear-cut localization to the urinary tract. And this is called the atypical features of UTI, which are seen commonly in elderly population, in children, where they may not refer any symptom to urinary tract. In people who are immunosuppressed, like patients who are getting steroid for an autoimmune disease, or a patient of renal transplant, or patient who is diabetic. Here the presentation could be just like a gastroenteritis. The patient comes with vomiting, loose motion, shock, and jaundice. And this is a typical septic syndrome that has to be appropriately analyzed in the context to make a diagnosis of urosepsis. So these symptoms, which may look to the common physician as gastroenteritis, could be a symptom of UTI in elderly, particularly that we see, and in immunosuppressed. So one has to have a high index of suspicion when we see a patient with this kind of presentation. Because UTI is one of the commonest infection seen throughout the world. The clinical pyelonephritis or the acute pyelonephritis can present with a classical symptom of that we talked about: loin pain, rigor, as well as fever, but it could have other presentations in the form of complicated acute pyelonephritis with emphysematous changes. That is, a lot of gas are present in the kidney or in outside the kidney, which is an extended emphysematous pyelonephritis. It could be associated with papillary necrosis, which is presenting as a kind of acute renal failure or pain. There could be a presentation in the form of occult acute pyelonephritis, subacute pyelonephritis, called sepsis syndrome, where you may not have any symptom pertaining to kidney, but kidney is seen on radiological evaluation to have infection, but it has spread to the bloodstream, producing a sepsis syndrome. Few patients have recurrent or relapsing pyelonephritis, acute pyelonephritis, and if the things are not taken care with the obstruction, it can present with xanthogranulomatoid pyelonephritis or malakoplakia, mimicking like a malignancy. The term chronic pyelonephritis has gone out of use, and this is basically referred as a chronic interstitial nephritis, which is usually associated with VOR, obstruction, stone, and many times with drugs. So chronic pyelonephritis is a radiological diagnosis. One of the cause of chronic pyelonephritis is infection, and this is a radiological term and no longer used. It has to be used in the appropriate context based on the clinical profile. The diagnosis of pyelonephritis or the cystitis is based on the positive urine analysis that we talked about, presence of pyuria, that is we defined as more than 10 WBC per high power filled in, which is centrifuge urine, along with leukocyte esterase test positivity on the stick test, which indicates the presence of leukocyte which contains that enzyme esterase, and nitrite positivity indicating bacteria in the urine which has converted nitrate to nitrite. It is usually seen positive in people who are having a gram-negative bacterial infection like E. coli or Klebsiella. Positive urine culture is defined as when person is not having any catheter. More than 10 to power 5 is defined as classical positive culture report, but lower culture report of 10 to power 2 to 10 to power 4 can also be considered positive in presence of symptoms which are classical. In a patient who is catheterized, the presence of more than 10 to the power 3 this coliform unit is suggestive of urinary tract infection. When a person has high fever, even the blood cultures could support the diagnosis of pyelonephritis. And if you find E. coli in the blood along with E. coli in the urine, this is a classical proof that the kidney infection has spread to the blood, and that is called urosepsis. So culture along with the urine analysis by microscopy as well as stick test is to make a diagnosis of pyelonephritis. So if we look at the whole UTI group, the symptoms, signs, and the diagnosis, if a person is symptomatic with the symptoms, and that is likely to be true UTI. A person has presence of pyuria and bacteriuria on the culture. But if person has only pyuria with symptoms but less significant bacteriuria, it could be still be a kind of cystitis or true UTI. That is if the bacterial urea is between 10 to the power 2 to 10 to the power 4. But if the patient has pyuria with no bacteriuria or is below 10 to the power 2 bacteriuria, insignificant bacteriuria, it could be because of the chlamydial infection or non-gonococcal urethritis. So it is a urethritis because of atypical organism where treatment may be different. And if the person has symptoms of UTI, but there is no bacteria, no pyuria, then this could be a functional symptom of acute urethral syndrome or unexplained urethral symptoms. Patients many times have bacteriuria, pyuria, but they are not symptomatic, and that is called asymptomatic bacteriuria. And when there is no bacteria, but presence of pyuria and no symptom, it could be considered as sterile pyuria. So there are many kind of terminologies to be used, and this terminology actually defines what is the way to go ahead. Pyuria by definition is 10 cells per high in spun urine, and the spinning of the urine has to be done at 2000 revolutions per minute for 5 minutes. Sterile pyuria is seen in situation of chronic prostatitis, steroid use, analgesic abuse, stone, etc. And hence pus cells should not be considered as a reason to start an antibiotic therapy. When we talk about UTI, pyelonephritis, complicated pyelonephritis, the risk of recurrence, the common things that is listed in the slide are the risk factors for recurrence, and it has to be appropriately treated to prevent the occurrence of recurrence of UTI. That is, obstruction is one of the commonest cause of repeated UTI, stricture, urethral stricture, benign prostatic hypertrophy, stone, and neoplasm of any type like carcinoma cervix producing a kind of obstruction of the lower urinary tract can produce the risk of infection. Diabetes mellitus is considered to be one of the commonest factor for risk of recurrence if diabetes is not controlled, or it's because of diabetic cystopathy, where the bladder is not getting properly drained because of bladder paralysis that happens, and person is having overflow incontinence. And acid abuse has been listed as one of the cause of recurrence, which is quite common in females because of the low back pain. VUR, vesicular reflux, is one of the cause of recurrence, particularly in children of repeated UTI. Any form of urethral catheterization and instrumentation is a risk factor for recurrence, and it has to be always kept in mind. Renal disease like polycystic kidney disease, medullary sponge kidney, horseshoe kidney with the ectopic location, or ectopic kidney is also a risk factor for recurrent UTI. The electrolyte disturbance, particularly hypokalemia and hypocalcemia, is also has been referred to as a risk factor for recurrence, and that kind of things we see in a patient who has renal tubular acidosis or any other form of disease which produces this electrolyte disturbance. So the question is that once we make a diagnosis of a UTI, do we need to investigate all the patients in a detailed way? It is said that we should have certain factors to decide how much to investigate. It is said that any male patient who is developing UTI should be investigated. Any female patient with recurrent UTI should be investigated with the detailed radiological evaluation and neurological evaluation. Any complicated UTI where the patient has developed some complication requiring hospitalization has to be investigated. Any person who has history of hematuria, stone disease, or voiding disturbance, that is, he becomes incontinent, this should be investigated. And any child with pyelonephritis is to be investigated because they have high incidence of CACUT. The word CACUT means congenital anomaly of kidney and urinary tract, that is in the form of VUR, in the form of pelvic obstruction, double ureter. There are many other forms of CACUT which can predispose the person to develop recurrent UTI. So these are the situations where you need to investigate radiologically by the test which is listed, that X-ray, KOB. Intravenous pyelography was done in the previous time, and now we do a CT pyelogram, contrast CT to get an idea about the kidney disease. Widening cystoarthrogram, MCG done in all female young patients who present with recurrent UTI to exclude the possibility of posterior valve as well as vesicular reflux. Ultrasound examination is the first radiological tests, many patients have UTI, and even in the pregnancy, which can present with urosepsis. CT scan, abdomen with contrast, and MR urography may be done in appropriate patient. And occasionally we do renal scintigraphy, particularly to look at the scars by DMSA scan or a DTP scan to see the kidney function. So there are different tests available, and algorithms will be different based on the situation where you are investigating a patient of UTI. Did we just give you a picture of a patient who has been getting treated with recurrent UTI in from pediatric age group to the adult age group? This is a patient. What we see is the plain X-ray. There's a bulging flank as if there's an ascites. So this was a patient who was having prune belly syndrome. There was no muscle in the lower part of abdomen, and hence the muscle was lax, and that's why the belly was bulging on the left side as shown by the arrows. And this patient had a MCUG, the mixture-T cystoarthrogram, for evaluating fever with sepsis and pyuria. What we see is that the bladder outlines are not normal. It is having circulation, and part of the contrast in the bladder has gone into the ureter on both the sides, suggesting that this is a patient who is having a kind of vesico-ureteral reflux bilaterally with a bladder outline not normal, suggesting it could be a neurogenic bladder associated with prune belly syndrome. And this patient was having a recurrent UTI. And in the follow-up of 30 years, in my follow-up, the patient ultimately ended up on dialysis. He's at the moment getting hemodialysis. And after his treatment, he never had a kind of urine infection there, because we could drain the bladder by the CIC, that is complete, there's clean intermittent catheterization. So patient who was in a follow-up for 20 years had no UTI with the CIC, and though because of repeated UTI in the past, he has gone into end-stage renal failure. So this is a diagnosis made based on the MCUG and the clinical profile. This was a patient who was having recurrent UTI. This is a young patient who was having a recurrent UTI. On the left side, what you see, the MCUG is showing the bladder outline is good, but on the left side, you are seeing a kind of reflux of the contrast into the ureter as well as in the kidney, which was a grade 5 reflux on the left side, presenting with UTI. And this patient requires an appropriate follow-up to decide the treatment as well as the plan to prevent the risk of kidney failure. What you see on the right side is a bladder outline which is circulated with multiple outpouching, and the lower part of the bladder we see a big kind of swelled structure that was a posterior part of the urethra which is swelled because of obstruction down. So this is a patient who is having posterior urethral valve which requires to be operated so the bladder comes, is properly voided, and the infection gets better because the obstruction is one of the common causes of UTI. And if it is not treated in time, it leads to end-stage renal failure requiring dialysis in children. This is another patient who has come for an opinion from after getting evaluated at CMC Vellore. What is a child who is having a kind of VOR on the left side. What we see in the nuclear study, that is a kind of study, a DTP scan, what we see on one side, there's a lot of contrast, on the other side, lesser contrast. So that shows that both the kidneys are functioning, but one kidney is having lesser function compared to the other function. So this is a way to evaluate the patient in the follow-up to decide what is the appropriate action. A patient being evaluated for kidney donation. On the left side, what we see is on a horseshoe kidney. He was never symptomatic, and what we see is that patient had a kind of fusion of the kidney on the CT scan on the lower part. So he was rejected for kidney donation. But this is one of the causes of recurrent UTI. This patient was asymptomatic. He was not having any UTI. What we see in the plain X-ray in this patient is bilateral kind of stones with a fusion. So this was a patient of horseshoe kidney with stones because of calcium oxalate stone. It was a patient of calcium hyperoxaluria with horseshoe kidney going into end-stage renal failure, which could be picked up on the plain X-ray KOB. Contrast enhanced CT in a patient who is presenting with sepsis syndrome. What we see on the left side is multiple hypotenuse areas which are said to be a kind of evolving abscess. So in the right kidney. So this kind of picture, if it is available, this proves the point that this patient is having acute pyelonephritis. But we hardly do these tests in patients who are responding to treatment. On the left side, what we see is that the kidney on the left is showing multiple areas of hypodensity, and it was a renal carbuncle in a diabetic patient. which was seen on both the sides, but on one side was quite apparent. So this is a patient of diabetes with repeated multiple kind of hypodensity because of abscesses developing in the kidney. This was a patient long time back, maybe in 1994, when patient presented with fever, shaking, chills, and kidney failure. What we see in the left kidney is presence of gas, which is extending from kidney into the parenchyma, outside the parenchyma. It was a patient of emphysematic pyelonephritis in a presenting with AKI, acute kidney injury. So these are the things which requires a kind of evaluation, presence of gas in the kidney. And on the CT scan, you see the kidney replaced by gas, with gas extending into the muscle plane in the thigh, that you can see clearly. So it was an extensive gas collection spreading into thigh in a patient who was totally uncontrolled diabetes, 48-year-old male presenting with AKI, was recovered with the treatment. One other form of the UTI is called pub syndrome, that is a purple urinary bag syndrome, where the urine looks red in the tube. And these are usually associated with bacteria, constipation, and particularly females who are on catheter. And if we send the urine for culture, we'll find Providencia, that Klebsiella, this doesn't require therapy. So this purple urine that is just a pigment which it is said that asymptomatic bacteriuria is quite common. And as the age increases, the person will have higher chances of developing asymptomatic bacteria. This is quite common in those who are having urea present in the urine, and it need not be treated. And except for the population of pregnant women, in other situations, the patients should never be treated for asymptomatic bacteria. Dialysis patient who is passing less amount of urine, if we send the urine for culture, we find the urine is positive for bacteria, and it should not be treated based on that alone. Asymptomatic bacteria, therefore, is quite common and is generally a benign condition, and treat only if the person is having pregnancy. That's the only situation it is recommended. And in patient who has to undergo some urological procedure where mucosal bleeding is expected, because from that you can have urosepsis. This does not include placement of urinary catheter. Any person who is being catheterized then who has asymptomatic bacteria need not be treated. Take out the catheter and put a new catheter. That is the concept. This is a patient who was having
Dr. Jha, your voice is...
What we see is that the left side, xanthogenic. Hello?
Your voice is breaking up.
Okay. What to do? Let me stop share and start again.
Yeah, you can do that.
It is fine, but sometimes it starts breaking. I
Yeah,
think
sometimes it just got, I think the connection gets slower.
So those for that, I have no way to be sure what to do, etc.
Yeah, I know.
So
I think it's working fine for now. Sorry for interruption.
Okay. So this was a picture I was showing, that this is called xanthogranulomatosis pyelonephritis. What you see, that both the kidneys have stone and repeated urinary tract infection, and the left kidney has become very large. That suggests that this is a kind of kidney which is inflamed, and it may mimic like a cancer, etc. So this was a patient of xanthogranulomatosis pyelonephritis with stone disease, which is associated with repeated urinary tract infection. In the recent report from the Indian Council of Medical Research, it has been reported that microbiologically we are finding organisms which are showing a very high degree of resistance. And the commonest organism in UTI has been the Enterobacteria C group of organisms, commonest being E. coli, followed by Klebsiella. And other species are shown, Enterococcus species also there. Staphylococcus is the least positive organism, and hence we have to choose our drug as per the prevalence of this infection in the society. When we talk about antibacterial therapy, 6 terminology has to be understood because these are terms which are commonly referred in the literature. Enterobacteriaceae, it refers to E. coli and Klebsiella pneumoniae, ESBL. And when you have this enterobacteria is resistant to beta-lactamase, it is called ESBL. Or if it is resistant to carbapenem, it is called CRE, that is carbapenem-resistant Enterobacteriaceae. There's a group of bacteria which is called non-fermenters, and commonest being this Pseudomonas aeruginosa and the Acinetobacter baumannii. They are usually carbapenem-resistant. Beta-lactamases and carbapenemase are the class A, B, C, and D type of beta-lactamase, and that has to be understood when we talk about the beta-lactamases. These are the terms which are referred. MDR means the multidrug resistant bacteria, which is where the antibacterial is effective. 3 classes the antibacterial is ineffective. That is 3 big groups, like patients who are not having a response to ESBL, who are not having a response to aminoglycoside, where we are not able to give a third group of drugs like carbapenem. So if 3 broad groups are resistant, it's called multi-drug resistant. And XDR means this extended drug resistance, means resistance to all known classes except 1 or 2 last line drugs that is available, that we'll discuss in the subsequent slide. MRSA is a term which is used, that is methicillin-resistant Staphylococcus aureus, which is usually used in context of Staphylococcus. And VR is a kind of vancomycin-resistant this enterococci. These are terms which are used when you're talking about antibacterial bacterial resistance. The treatment approach in general is guided by the ICMR guidelines or based on the American guidelines or CDC recommendation. We also take help of ID specialists where it is available in a difficult situation. We try to interact with the microbiologists or go at the local data from the ICMR to decide which is the organism which is prevalent and which is the antibiotic which is usually likely to be effective. And physicians' knowledge of over the years for how to go about it and experience, and local patient's compulsion, whether the patient wants only an injectable, the best drug, etc. Based on that, we decide. So this is a slide which is from the CDC guideline that in a patient who is having acute uncomplicated cystitis, the drug of choice is nitrofurantoin, trimethoprim, fosfomycin can be used, oral beta-lactam antibody like amoxicillin, ciprofloxacin, though he used is not the drug preferred, fluoroquinolones can be used. In pyelonephritis, these are drugs to be avoided as per the CDC guidelines, and we follow this guideline because this is the same thing that is advocated by the ICMR. So ICMR 2019 has suggested what are drugs to choose for acute cystitis: nitrofurantoin or cotrimoxazole or fosfomycin. Fosfomycin is quite a costly drug, and we try to prefer to use nitrofurantoin. Cotrimoxazole is a drug which is usually used in children for treating cystitis. Acute pyelonephritis is to be treated with beta-lactam antibiotic, piperacin, tazobactam, or ertapenem, because most of the ESBL strains are resistant to the older drugs that is recommended by CDC, like Monosef or ceftriaxone. That is the drug which is recommended by the CDC, but piperacin, tazobactam, or ertapenem is a drug as per the ICMR guidelines. We may use the other alternative drugs like imipenem, meropenem, or amikacin. Prostatitis, the drug of choice as per the ICMR is ertapenem, but we can use the other drug group. Epididyma orchitis, the drug of choice is ceftriaxone or doxycycline. And if person is suspecting any other kind of problem of sexually transmitted disease, the same drug is used. So we use the different drugs as per the ICMR guideline based on the presentation of the patient. ICMR has recommended these antibiotic therapy based on resistance pattern, because it has been referred to in the guideline that initial empiric therapy for infections caused by Enterobacteriaceae, that is E. coli and Klebsiella, which is presenting a pyelonephritis, should always be with an agent which is active against the ESBL strain, the extended spectrum beta-lactam strain producing. A carbapenem for those who are very sick, or with a beta-lactam and beta-lactam inhibitor like piperacin, tazobactam for those who are less sick. And one has to also remember the dose is important. Many times we find the doses are given in low dose. For example, ciprofloxacin, sulbactam, the standard dose I see is 1.5 gram BD, but the dose that is recommended is 3 grams twice daily. Similarly, the other drugs which are listed has to be given in appropriate dose. Colistin is used only in situation of all drug resistant, that is extended drug resistant bacteria, where you have to use 9 million units IV stat followed by 4.5 twice per day, provided the kidney function is good. So we have to be familiar with what is the drug dose and what is the full dose to be given in such situation. In one of the studies which are published in our Indian journal, when they looked at the acute pyelonephritis and culture, 89% of patients were having E. coli as a cause and 9% has Klebsiella. And if they looked at the drug resistance pattern, they found that ceftriaxone, which is a good drug, there's 0% kind of this benefit. The commonest drug, 100% benefit is there with ertapenem, imipenem, meropenem, and other drugs like cefoperazone, sulbactam, 90%. So we have to use a drug of this type compared to the earlier drugs like ceftriaxone, which is still being recommended by CDC for treating acute pyelonephritis. This one more few words about CAUTI, that is catheter-associated UTI. CDC surveillance definition is shown in the slide, that we have to understand that 3 criteria has to be met to say that this person is having catheter-associated UTI. The catheter should be in place for more than 2 days when it being placed for the first time. Urine culture should have not more than 2 organisms, and 1 organism should be more than 10 per 5, and presence of at least one of the following clinical feature of fever, tenderness, costal angle tenderness, urinary urgency, urinary frequency, or dysuria. So if all the 3 criteria are met, then only one can say that it is catheter-associated UTI and it has to be treated appropriately. In absence of that, it will be considered as asymptomatic bacteria. And in this context, it is said by the European guidelines, and which is followed all over the world, that do not carry out routine culture in an asymptomatic catheterized patient and do not try to treat it. So to prevent UTI, we have to understand that we have to increase the fluid intake, particularly in the weather which is so much of heat around, because passing lesser amount of urine, less voiding, increase the risk of UTI in predisposed. One has to take regularly the drugs which are known to prevent UTI, like postpartum prophylaxis in case that is the case. Last dose of the antibiotics should be taken after urination, voiding after sex, because in case it is happening recurrent UTI in females, they have to be advised that they should try to pass urine after the sex. Careful removal of sanitary pads, because it has been found that this is also one of the risk factors for UTI. And people who are using diapers for incontinence, we have found that that is also increase the risk of UTI. We urge them not to use diapers in case they are having UTI. Avoid constipation, because somehow the gut as well as the bladder drainage is linked, and people who are constipated are found to have more chances of UTI. Using a smaller size catheter in adult males, like less than 16 French catheter, to allow the secretions from the side of catheter to come out to reduce the risk of UTI. And once we look at the predisposing factors, and common predisposing factors in our experiences, diabetes and obstruction. These are the things, and sex maybe in females, which has to be taken care of. So my choice, like we have so many antibiotics to be prescribed in a patient of UTI. The first level treatment for treating lower tract infection in nitrofurantoin, or cefixime clovulanic acid, or quinolone, particularly ciprofloxacin. Ceftriaxone is not a drug to be prescribed except in a pediatric age group. That is my first choice. Community acquired UTI in the OPD, this is the prescription I give. Second level therapy, in case the patient is not responding to this therapy, is to use the cephalosporins with beta-lactamase inhibitors like magnesium, cefoperazone, sulbactam, or piperacillin tazobactam with amino glycoside. And this is the situation that we see in patients who are having diabetes with the UTI and getting hospitalized. Third level drug, when person is having a kind of shock-like picture, unstable hemodynamics, we start with carbapenem, meropenem, or imipenem, and decide. And in patient who is having a kind of poor response to these therapies, colistin, fosfomycin, ceftazidime, avibactam, biapenem, iloris, etc. can be used. Other measures in a patient who are having a UTI repeatedly is also important, because, and that is called symptomatic relief with cranberry extract, local estrogen, probiotic, alkalizers, anticholinergics, avoidance of spicy diet, because we find that this is a very important kind of contributor for dysuria, and a lot of non-veg producing a lot of acidosis in the urine, and plenty of water. Newer antibiotics, for people to understand that these are the drugs which are now come into practice. can be used appropriately, like Javiseptra, Ceftriaxone, Avibactam, Ceftriaxone with Sulbactam, and disodium EDTA, aminoglycoside, the new aminoglycoside, isipamycin, arbitration can be used in situation of drug resistance, and biopenem is another drug which is useful in situation of drug resistance. So to conclude, patient with cystitis can be treated empirically with 5 days of antibiotics with no culture. Nitrite and leukocyte esterase test is enough to support the diagnosis of cystitis. Acute pyelonephritis, culture is needed most of the time. It is said that 7 days treatment is required most. 14 days treatment can be done in situation of immunocompromised state like transplant. No radiological test is required unless an extra risk we have based on the history. Do not culture in a catheterized patient unless symptoms are there, because asymptomatic bacteriuria is quite common, and not to treat. Catheter-associated UTI, treat for 10 days if the history supports the diagnosis. ABP, that is acute bacterial prostatitis, in males comes with a voiding problem. It has to understand that when the prostate gets inflamed, the urethra gets narrowed and produces a voiding problem, and this has to be suspected. And we have to do a kind of digital rectal examination carefully, or transrectal ultrasound to confirm that prostate is enlarged, involved, or having an abscess. And this has to be treated for 14 to 28 days with the treatment. The drug of choice for prolonging the treatment of bacterial prostatitis is to use quinolones, which has got a high kind of penetration, or cotrimoxazole. Recurrent cystitis, in particularly postmenopausal females, can be treated with vaginal cream, particularly estrogen cream, or postpartum antibiotics. Candida is grown commonly in urine, and it should not be treated empirically. Repeat after catheter removal to see if the candida is there or not, and use a clinical sense to decide if the candida therapy is required or not. SGLT2 inhibitor, which is a part of treating many kind of comorbidities like diabetes, heart disease, heart failure, can be continued if there are no additional risk factor for recurrence. Treat infection, but not colonization or contamination. Be aware of the antibiotic resistant pattern in your locality to decide which drug to choose. And that is all that I wish to share with you all. Back to the organizers for any comment or questions.
Thank you, Dr. Jha, for excellent presentation. I would like to open the floor for the question answers. Hi, anybody has questions on regarding this? Dr. Monica, any comments?
Thank you, Dr. Jha. It was a very practical conversation, and it's always nice to always remind ourselves that every dysuria does not require antimicrobial therapy. It's always important to understand the differential. Thank you for a fantastic talk.
Thank you. Thank you.
I don't think we have any questions. It was well explained. I think the session was completed properly. We are right on time to end this session. I would say thank you so much, Dr. Ratan Jha, for joining in and spreading your knowledge with us. We will be back again with other sessions. Thank you for joining in on Saturday. Thank you.
Thank you.
Take care, everyone. See you again.